One.
Good morning, folks. This is the Central District Board of Health meeting for December 16th, 2022. It is now 8:30 in the morning. I'll introduce myself as presiding chair. I'm Betty Ann Nelson, representing Elmore County, along with Representative Megan Blanksma. And I thank the public that has chosen to join us today for your participation. At this point, I will call the meeting to order, and the roll call is next, starting with Ada County. Dr. Young. Rael Labrador. Dr. Cole. Elmore County. Megan Blanksma.
Blanksma here.
Thank you, Megan. Boise County.
Boise County Commissioner Sturby.
I'm sorry, can you repeat your name?
Commissioner Sturb is here. Yes, ma'am.
Thank you. I couldn't quite hear you. Valley County?
Commissioner Hasbrook here.
Okay, thank you, folks. We do have a quorum, so we will proceed with our agenda. Under action items, are there any changes to the agenda?
No changes to the agenda, Madam Chair.
Okay, and I don't believe we had any of the public sign up to speak today, is that correct?
That's correct.
Okay. Proceeding under new business, we need a motion to vote on the minutes for approval of our October 21st, 2022 board meeting. Is there any additions or corrections to those?
Madam Chair will make a motion to approve the minutes as presented.
Okay, thank you, Al. Is there a second? Thank you, Dr. Young. Go ahead and proceed with the vote to approve those minutes, starting with Ada County. Dr. Young.
Aye.
Rael Labrador. Dr. Cole. Elmore County.
Blanksma, yes.
Thank you, Megan. Boise County, Ryan.
Commissioner Sturb, aye.
Thank you. Valley County.
Commissioner Hasbrook, aye.
Okay, those minutes stand approved as presented, and we will proceed with the introduction of new staff by our Director Duke.
Okay, so we have three new staff I would like to introduce today. We're going to start with Maria Ortega, and she is our new Communications and Marketing Manager. Maria joined us on November 14th as our Marketing and Communications Manager. She has over 20 years of experience in marketing and communications, and over the last 10 years here in Idaho. She has worked as Marketing and Communications Manager for the College of Southern Idaho, and then more recently at the University of Idaho, Boise campus. Maria is very interested in health communications. She's completed a master's in public relations with an emphasis on health communications at Washington State University. Is looking forward to helping increase community awareness about CDH's many public health programs. So, welcome, Maria. I don't know if you'd like to say anything or...
No, just thank you, Nadia. I'm excited to join the group and help promote what we're doing. I'm looking forward to continue the IO role, but also grow the marketing aspect of the department and create more awareness and growth.
Welcome.
And next we have Dylan Richards. Dylan is our communicable disease control program manager in our division of community and environmental health. He has a bachelor's of science degree in public health from BYU, Idaho, which he received in April 2019. He completed his master's of public health and health leadership in May of 2022 and did an internship at CDH. I think that was your first introduction to our organization. Spent a year and a half with BSU as a public health program assistant, and then 4 months left the state of Idaho to move to Texas, 4 months to assist down there as a temporary position, helping them with the MPX response before coming back to Idaho to be your quiet communicable disease control program manager. Not much ever going on in that sector of our agency.
Knock on wood. So.
Yeah, right.
But
So,
excited to be here, excited to work with the community team to improve transmission rates and best of what we can bring. organizations here in the county, so team that I work with, decided to here and be a part of this organization.
Welcome.
Thank you.
Last, not least, as they say, Heidi Hopkins. Heidi is our public health preparedness program manager, but that's not where she started with CDH. She actually spent quite a bit of time early in the pandemic, joined our team to help with the COVID response and worked her way up to be our manager over all of our COVID investigators before shifting over to the public health preparedness program. So they work very closely together, preparedness and communicable disease, and will continue to do that. She has a Bachelor of Science in Athletic Training from the University of Nevada, Las Vegas, master's degree in sports science from the University of the Pacific in California, and she is a licensed athletic trainer and has previously done a lot of work in the area of sports medicine. And as I said, she's been with CDH since June 2020, so not much after we had our first case in March. So welcome, Heidi, and you're welcome to share some thoughts.
Very nice to meet you. I appreciate moving over to the public health preparedness team and just continuing the great work that they are. I actually was on a Valley County meeting the other day. And
I thought I
saw
recognized
you
that name.
there, so yeah, I did too.
Oh,
Thank you.
that's great. We're trying to start new policy that if you're gonna zoom in, you gotta put your face on the screens.
Like a plan.
So you recognize you, because all we get's a name, and it's like, you walk right past this person, not know. Welcome.
Thank you. Thank you.
That concludes. Okay, proceeding on, we're going to talk to Laurel about our fiscal year financial report. So go ahead, Laurel.
Okay, thank you, Madam Chair. And get Dustin to pull up the screen, please. You have it in your board packets as well. Go ahead and start presenting, and then we'll see it on the screen just momentarily. So the report that you have in front of you is through, there we go, through the end of November, which is about 42% of the way through the fiscal year. We'll just get right into revenue. So revenues for community environmental health are on track, 39% of where we plan to be. We'll make a note that we're in renewal season right now, so we expect to continue to see that revenue increase between now and the next board meeting. This is typically where we get above the percentage that we plan to be, and then we kind of even back out through the end of the fiscal year. For family and clinic services, we're at 42% as well, so exactly where we plan to be at this time of the year. Just to note, there are other revenue for FCS, does include the home visitation fees. Percentage that you see that off more than the others, but again, it does even out to being at 42% of where we expect to be. Overall, our agency revenue is at 39% for the fiscal year so far, so very close to what we anticipated. I'll point out here that you can see county contributions are at 22%. And I know we've talked about that a couple times in these meetings. That's based on when the county payments are submitted. As just a reminder there, we don't have a cash flow issue, so it's okay if they're coming in on a cycle that isn't exactly aligned with being even throughout the fiscal year. It doesn't impact what we're able to do with our funds. So it appears to bring our overall revenue down to 35%, but we are right on track, and there's no cash flow issue being at 22% with the incoming county funds there. Another note I want to point out here, just because it's a percentage that you see is significantly off, is that interest revenue. Previous 2 years, our interest revenue was below what we expected it to be, so we readjusted this year based on those past 2 years, and this year interest revenues have begun to go back up, so it looks like we're way above what we anticipated for interest revenue, and we'll adjust that during the budget revision period, which we're in right now.
Laurel, question on that. Is there any kind of restrictions as far as code where you can invest or how much money you can invest, or is that just, you're just in the state government pool, or?
It is in the state government pool, and I would have to ask Bailey for what the restrictions are on that and what the guidelines are. She's much more close to what the investments are.
Can the health district invest in like 3 month and 6 month CDs, or do we have to
I don't believe so, but I would have to get with Bailey on
That's
what
one of the things that the county's kind of dealing with right now, all the counties, and we want to be able to take that money and invest it somewhere else besides the state. And there are certain codes that says you can and how much, and I just wondered if we had the same.
Yeah, I'll find out and get back to you on that.
Right now, you could get 3 months for around 4%. So it's a pretty good deal right now.
Yeah.
And if you can't do it legally, then
Not a good deal.
be careful, but I think it's be something that maybe we want to look into.
Yeah, I'll have a conversation with Bailey and Russ and see what if there are options there.
Another question before you move on. I'm assuming too that you also get a lot of county contributions probably the end of January. Over January.
Yes, that's correct.
Thank you.
Okay, looking at our expenditures, if you look across the bottom bold line of expenditures, you can see that personnel's at 38% of where we plan to be. Both operating and capital are below what we anticipated being at this point in the year. Overall, our expenditures are at about 33% of our planned budget, being almost 42% of the way into the fiscal year. So that is a bit below where we plan to be. We know for capital expenditures, those aren't evenly distributed month to month. So we do typically see fluctuations in capital throughout the year. And then we'll continue to track personnel and operating and make adjustments during the budget revision period if we need to. Operating is about over 10% below where we thought we'd be at this point in the year. So look at that as Bailey's working with the program managers and see if we need to make any adjustments.
Question on that, on the personnel, are you fully staffed now, pretty much?
We are pretty close to being fully staffed, and I do have a note about that on the next page too as we're looking at it. So some of our personnel, what has continued to be a vacancy issue. We had division administrator vacancy for 2 of the division administrators this year. We had some program manager vacancies and then some entry-level positions as well. But we have begun to see one drastic reduction in turnover rates. And we've also seen that for all the open positions that we're posting, we have an increase in applicants and an increase in the quality of applicants. So we're beginning to see that shift pretty significantly. So we are very close to being fully staffed. There's about 3 or 4 positions that we're really having trouble filling, and we continue to work on those. But every time we post them, some of them have posted 3 or 4 times. We are getting more applicants every time, just that there's a few. The medical assistant position and a financial technician specifically have been quite difficult to fill.
Is that a matter of because of salary or is that because of qualification?
Seems to be a little bit of both. Medical assistant is a shortage throughout our region. That's not, wages have gone up probably $3 to $4 an hour in the last couple of years. And we're pretty close to on track with what the other local providers are paying medical assistants. Seems to be a shortage in the market. And the financial technician, Bailey and I were chatting about that this week too. There seems to be a shortage nationally. She's been hearing in kind of entry-level finance positions and even people going into the financial field at the collegiate level. Seems to be indicative of some trends that are bigger than just CDH.
Yeah, but it's really good news that we're starting to fill them.
Yes.
Yes. That's the people are applying and we're starting to fill because everybody's going through it. Okay.
Okay, I'll go ahead and move on to page 2. This is our comparison this fiscal year to the last 2 fiscal years. I just would like to point out a few things on this page. So for community environmental health, you can see that our food and child fare fees continue to increase. But for both land and sewage program, we're either even to where we were last year, or a little bit behind where we were this time last year. And as we've also talked about in this meeting, typically that means that growth is leveling off. So we're beginning to see that in our fee numbers that are coming in. For family and clinic services, some of the numbers have slight increases, some have slight decreases. Reproductive health and central care are both down slightly from last year, but our immunizations revenue has increased. Overall, FCS is performing very close this year to where it was last year. For the agency overall, our fee revenues are up by about $65,000. That's mostly due to community environmental health and then mostly due to the food program. So that's where we're seeing our biggest increase in our fee revenue. Under contracts, we continue to see increases in both FCS and CEH. That's as we plan to be, but that's just year over year continues to go up. Looking at our expenditures, as we talked about on the last page, personnel is under budget. Had those vacancies that I mentioned, but we have begun to see that shift in personnel. Our operating costs, as we saw on the last page, are under budget by about 25%. And those costs. Looks like we have a question online. Thanks, Matt, for pointing that out. I'll go ahead and turn it over to the question online. I proceed and then.
They're having a difficult time unmuting. They're not able to unmute, so.
Is that right?
I'm not sure.
It's like a mic issue based on the icon. Oh.
Okay, and Dustin, if you see any questions in the chat, please let me know. We can answer them that way as well. This is talking about operating costs being under where we plan to be, but we know those costs aren't always evenly distributed. And then for trustee and benefits, same with those. They're not always evenly distributed throughout the fiscal year. We tend to have two big pulses at the beginning of the fiscal year and the beginning of the calendar year. So pretty much what we would expect there, and that's the same with capital outlay. And we can go ahead and move
Question,
on.
before we move on, Laurel, under childcare and licensing, that one has gone up quite a bit. Are we seeing more daycares coming into the system now?
We are seeing more daycares, and Curtis, correct me if I'm wrong, I believe we're also covering other regions for our daycare inspection, so it's not just our district.
That's correct. So Region 4, District 4 is also covering District 5 out of Twin Falls, and so we are sending staff on a daily basis to District 5 to cover some of the complaints and the annual inspections that are occurring there.
So I'm assuming we're getting reimbursed for that?
We are. Madam Chair.
Yes, go ahead, Chris.
So just by way of some background on that, the state of Idaho moved to a single entity contract. So they were only willing to contract with one public health district. So that's us. And then we're responsible. Basically, we get administrative costs to do that for the 7 public health districts. And then Public Health District 5 is basically unable to fulfill their obligations, I understand, because of staffing shortages. So either we weren't going to be able to meet our contract obligations, or we're going to have to figure out how to cover them. So it's not costing Central District Health out of like county budgets for generating the revenue, but it is an added time burden.
There's the other district besides 5 is where we do inspections elsewhere. They have enough staff.
Correct. Just Public Health District 5 out of Twin Falls had a staff shortage, and which I'm not sure. I would have thought by now, with what we're starting to see with the change in the number of applicants and the quality of applicants, that I would hope they'd be able to come back on board.
How many inspectors do you have?
In total, we have going to Twin Falls. We have one inspector that is going there fairly routinely, 2 or 3 days a week, and then the supervisor that is also participating in some of those inspections on a weekly basis. So we're sending on average, 2 inspectors a week to cover the Twin Falls area. We're covering all complaints and annual inspections.
It's kind of interesting they can't find their own staff. It's going to be long-term. So we're responsible for all 7 districts. If the rest of the districts just say we're not going to fund that position and turn it over to 4, they have to handle it all.
I'm sure. Yeah, I don't know what happened just because of the logistics of trying to coordinate that. It would be, I think, nearly impossible to do. Twin Falls is, other than Public Health District 3, Twin Falls is one of our neighboring districts. So our goal was to keep the program intact, meet the contract requirements, but that's a discussion that Curtis and his team will be having with Twin Falls to find out, what their long-term plan is to hire somebody and fulfill their obligations under the agreement we have with them. But for right now, we have to cover for them.
It's interesting to know.
They've experienced, I think, a growth surge down there similar to our district in Magic Valley.
Okay, thank you, Linda.
And looking at the last page, page 3 of the financial report, which is the cash balance statement. Continue to see the same trends that we've been seeing here as well. Our cash balances at the end of the month of November were right at 8 million. Our reserve fund designations, if you look there, show little activity so far this year. So for that, the completion of the remodel, we've only been invoiced so far for $13,500. We are in the very final phases of that, the completion of the remodel. We're just finishing up part of the community environmental health area of the building right now. So those invoices should all be coming in the next 4 to 6 weeks. So by the time we have the next board meeting, you should see the invoices there and a reduction of the balance that we've had on there for the last couple of years. And then the next item for our special projects and carryover designation is the environmental health system upgrades. And that's money that we set aside 2 fiscal years ago as well. So now that Curtis is in place, we've made a decision how we want to proceed on our environmental health system. And that is a rebuild of the system that we have in place right now. That's a little bit out of date, needs some enhancements to be able to function for what our inspectors need, and needs some more automations built in. So our plan is that for fiscal year 23, our IT team internally will be working on some pretty drastic upgrades to our inspection system with the goal of getting all of our inspections automated and able to be done on tablets or out in the field and not have to be reliant on any paper forms anymore. We're still doing a mix of both right now.
Or who's your software company?
We are actually, so the system that we have right now was built internally. We hired a contractor several years ago. For the upgrades, since we already have the basic structure in place, I think we're going to be able to handle that mostly with the IT stuff that we have in place now. If we do need to hire contractors, we're absolutely open to that as well. We do have a small IT team, but they're mighty, so see what we can do internally and
Well,
contract.
just keep in the back of your mind, I know the counties for years and years, it was Computer Arts was our software for a lot of our, and all of those are being rolled over into Tyler Technologies out of, I think they're out of Texas. About the same price, but a lot more friendly for you guys if you want to change something in outlay, how it lays out a form or whatever. We're finding that it's going to be awesome. The other thing we probably have thinking about bringing one of these tablets out, we need to start budgeting. Those take hits pretty hard. And keep that in mind for budget next year. Great news.
And the last item on the special project carryover designation is the employee retention, which the board approved. And we'll also see a reduction in that by the time of the next board meeting. Those retention incentives will go out in the January 6th paycheck. So thank you again for your approval of that, and we'll see a change in that project designation before the meeting. Okay, and then that brings our total cash balance undesignated unrestricted to just over $3 million. And again, that's on track with what we've seen. We are point out also that our operational reserve funds are right at that 3-month cash flow target that we want to. The board planned to stay there, maintaining that, and that still leaves us that undesignated balance of just over $3 million.
Yes, I can, Megan.
Yes.
Yes.
Yes. Yes.
Is there a reason that there's only a line item for it in FY23?
Yes, there is, and I'm not sure why Bailey wanted to call that out separately, but I know that she made a decision to have it as a separate line item, and I can get with her and find out what the reason for that is, Representative Blanksma, and get back to you.
Thank you. I would appreciate that because if we're going to start splitting it out, then I would like to know what previous years looked like too.
Okay. Thank you, Megan. All of a sudden, we can hear you better.
Yeah, well, I'm sorry about that. I don't think it was on my end, but thank you.
You might check to see if Raul and Commissioner Sturm can.
Yes, Raul and Commissioner Sturm, can you hear us?
I can hear
I
you.
can.
Can you hear me?
Okay, thank you. And we
Can you
heard
hear
both
me?
of you in that response.
Okay,
So
great.
thank you.
Thank you.
Hey, Laurel, you're done?
I'm right, sir.
Yeah. If I may, Curtis, this question is more for you. Are you seeing an issue environmentally with a lot of little nests of people moving into remote areas, into like the sheds we see and making them into homes? We're seeing that in our county. Old motorhomes, old travel trailers, we're seeing that pop up everywhere.
I don't know specifically how that's looking in each of the counties. I do know that our land program is working diligently to review everything that's been applied for and make sure that those applications are fully vetted and reviewed before anybody's allowed to proceed with construction on those. Not aware of anything, but we can definitely look into it. If you have specific questions or concerns, I'd be happy to take that information and research that and get back to you.
I don't know if Elk's seeing this, but we have such an influx. We don't have housing and people can't afford, things. So rather sad, but it could be a potential problem. So, okay, any further questions or discussions for Laurel? Okay, moving ahead then, Elk, you want to provide us an update on the executive council?
Well, I missed the last meeting. It was the same day I had a county commissioner meeting, but Russ attended and apparently wasn't really much discussed. The issue on the food fees is kind of gone away because we can't really find anybody who wants to take that on as far as the last I heard. I know Doug Center and Nez Perce County was approaching some of their legislators up there to see if they would take it on, and I have not heard back to see what's going to happen with any of that. I think we're still on for June at Coeur d'Alene for IAB. And other than that, there's really not much the executives really or trustees involved with any even needed. Yeah, we shall see. Maybe in June we can make that decision.
Russ, do you have something to add since you were there?
No, that's there. As you all know, there's a IAB resolution in support of removing the fees for food establishments that are set in Idaho code. And there's been, Commissioner Hasbrook talked about some discussion throughout the summer and early fall about finding legislative sponsors to carry a bill that would allow that to happen. It was submitted to the Idaho Association of Counties for their legislative committee to review, but it didn't make the, I don't know how it's prioritized, but it didn't make the top priorities. It's not of interest, but it's not one of the issues that IAC is actually going to actively work on. So I think it just lost its momentum. And then there is recently I learned that there's some interest out of the Public Health District 5. I don't know which legislators putting together some legislation to tax vaping products to try to create parity with tobacco so that it's a deterrent, increases the price of products and then serves as a deterrent for people to start. I don't have any information as far as which legislators may be involved in that or what, how likely it is to come forward, but that I learned about yesterday on a district director call.
Okay, any questions about the executive council?
Well, I think we're going to have probably, there'll be an opportunity if the board wants to travel to Coeur d'Alene in June to attend that. If not, it'll probably be proxies. get to that point, but I'm sure Russ will keep us in line. See where it goes.
Madam Chair?
Yes?
Yeah, a question. We've talked about this many times. When are our dues coming up for the association?
Madam Chair.
Yes, go ahead, Russ.
So just by way of just real quick background, the IAB sets the budget. That's one of the things that you all do during the business meeting each year. So once that budget's set, as that's drawn down, Public Health District 2 out of Lewiston is the district that is managing the budget. So they'll do an assessment to each of the public health districts, 1/7 based on where that budget is at, how much revenue they've collected, and basically how much money they have on hand. So that has not yet been set, Representative Blanksma, and I'm sure we'll hear more this spring as the districts are setting their budgets. What District 2 anticipates would be the shortfall coming into next year and then do the assessment. But I'm not sure as far as the timing.
Madam Chair.
Yes, go ahead, Al.
Russ, wasn't the last time, was it around $7,200? $7,000?
I'm sure
Yes, go ahead.
that's about correct. They wait till it's drawn down to a certain point
wanna give
and then
about
do an assessment, but it's
50
about
in there.
exactly about $50,000.
Madam Chair, another question, if I may.
Go ahead.
Yeah, so my understanding, and I'm going to keep revisiting this because I want to understand the value for that $7,000 or whatever they collect. My understanding is essentially they use it for the annual meeting. Is that correct? Or do they have other expenses that I am unaware of?
I'm sure.
Go ahead.
So it would be used in part for the annual meeting and also our payment to the Idaho Association of Counties as the public health districts or boards or members of the IDC. And then historically, it has been used to pay for a lobbyist to work on public health legislation on behalf of the boards based on the resolutions that were passed. So those are the three largest cost.
Okay, Madam Chairman, then one more comment.
Yes, go ahead, Megan.
Then I would like to suggest that we put that as an agenda item when it does occur rather than straight up paying it, because I think we need to revisit the value. And as the largest public health district, it might be more efficient to consider our own path rather than be tied down to what other districts necessarily want to do.
Madam Chair.
Yes, go ahead, Al.
You know, Megan, I think that's probably a good idea, at least something we need to think about. I know the last time IAC helped us a great deal on the 316 bill and helped us meet with those senators and write those bills and sit down and really get into the weeds on a lot of that stuff. So I think there is a value to have Seth and his group behind us on that, but I thought that, doesn't each district pay to IAC as well? Or do we do it all as a group?
Madam Chair,
Yes,
We
go
do
ahead.
it individually.
it all comes out of the
Yeah.
IAB, which
Budget, okay.
budget. So with Representative Blanksma's point, where I think that conversation should take place is at IAB. That, because once that budget's set, that budget was set with our participation, whoever was there, and voted by proxy. So the commitment was made. And I think what would be the most appropriate path is this June is that conversation take place during the business meeting when the IAB budget will be presented, and then you all can share your views as far as whether you want to continue to participate or not. Does that make sense? So that's how the budget gets set. But once it's set, you can't, I guess I don't see a reasonable way to say, well, we changed our mind. We don't want to pay into a budget that we all committed to. We all 7 boards. So again, you guys can map out your own path, but that's what I would suggest is the best approach, is to have the conversation during the business meeting when you're talking about the budget. And if you choose to step out of that process and no longer contribute, make it known then.
Madam Chair.
Yes, go ahead.
Interested, I don't know if you remember, maybe you remember, Megan, but I think our cost, the IAB cost for IAC, the lobbyist stuff was 12,000.
Correct.
So out of that 50, there's 12 that comes right out for IAC and all
Annually.
that. And that, I think, is worth keeping. I don't know about the rest of it, the annual conference, all that kind of stuff, if we need to be involved with that. But I do think we need to keep IAC on our side.
Madam Chair?
Yes, go ahead, Megan.
Yeah, independent of IAC, I think we need to be considering, limited involvement with that crew and allowing them to determine what Central District is going to do. And I think we need to have that discussion as a board, to what end we want to actually participate, because from my perspective, this has been a long, hard path to try to get that funding formula done, to try, to really get some work done where the other districts have actively opposed us. And so I think we should have that discussion and be prepared to make our opinions known on that issue.
Chair, so could we agenda this for, when is it, next meeting, January?
February.
February 17th?
If the calendar's approved.
So did you hear that, Megan? If the calendar's approved, it will be on the February 17th agenda.
That will be very difficult for me to attend for somewhat obvious reasons.
Right.
Just skip work. You don't need to be there.
Yeah, I happen to get a new position there that it's going to be difficult to skip.
Well, and to throw something else into the soup, I think you have a new trustee by then, don't you?
By June.
No, by January. Aren't I paid out at the end of the year?
We've done it on our fiscal year cycle, so the elections will take place in May.
Yeah.
Keeps changing the rules.
May of 2030.
Right.
2030? I think I'll be around then.
Okay, Megan, did you have anything else?
No, that's just my perennial drumbeat of why do we pay this money to IAB?
Right. Okay. Okay, proceeding with the agenda, we have a discussion and a vote on our next 2023 meeting schedule. Rush, you want to take that conversation, please?
Sure. So last year, I'd say not quite forever, but for as long as I've been here, we've not met in January. We've met in February, but we bumped that meeting up last year to January because of needing to shift funding for Nurse Family Partnership. So Donna, built the calendar based on our previous schedules, which was to meet in essentially every month, February, March, April, May, which is board meeting, budget hearing. As far as the schedule, June is the IAB meeting hosted by Public Health District 1 out of Coeur d'Alene this year. Then we would meet in August, October, and December, which again, this calendar is consistent with what we have historically done with the exception of last year.
Fiscal year's September 30. Right?
July 1 to June 30.
July 30 this fiscal year.
July 1, start of the next fiscal year for us. Yep, June 30 is the end. This budget, this calendar is before you to vote on. Once we get it finalized, then we'll publish it.
Thank you, Russ. Do I have a motion to approve the 2023 calendar as presented? Thank you, Jean. Is there a second?
Second.
Okay, thank you, El. Okay, the motion has been made and seconded to approve the 2023 calendar in front of you, and I will go ahead and call for a vote by county, starting with Ada County. Dr. Young?
Young, aye.
Raul Labrador?
Aye.
Dr. Cole, uh, Elmore County, Megan,
Aye.
Boise County, Ryan,
Aye.
and Valley County.
Strasburg, aye.
Okay, thank you, folks. That calendar stands approved for the coming year. Okay, proceeding, we have a report on an opioid settlement plan by Becca Sprague, our Health Policy and Promotion Manager, and Curtis, our Community Environmental Health Administrator. So take the floor, folks.
Chair, thank you. Unfortunately, Rebecca is not able to attend with us today, so unexpectedly, she will not be present. So I will be giving the presentation and sharing that with you. You should have a packet in your folder. And Dustin, if we can pull the slides up. Excellent, thank you. So we'll be talking about the opioid settlement funds that the district is receiving. We'll start off by giving a brief background on what medication-assisted treatment looks like, some of the medications that are utilized, the effectiveness of them, and then go into some of the goals, the intended outcomes, and then what our plan looks like over the next 3 years. It's a high-level plan at this point. There's not a tremendous amount of detail put into it, but we would like to be able to outline kind of a general idea of what we would like to do. And this would be in addition to the current preventive services that we're already engaged in and the things that are already occurring with the contracts that we already have in place. So this would all be in addition to what we currently have within the district. If you can look here at the background of, it's an overview of the opioid use, medication effectiveness. You can see there's 3 different types of medications that are there, and you can see the effectiveness of each one of them. Methadone is the preferred treatment for most individuals. It also requires additional certification by the SAMHSA, which is a board of mental health and substance use that helps to certify and ensure that medication-assisted treatment is delivered effectively and correctly. And so one of the things that we would be pursuing over the time period of this would be to certify our clinic and our location here as a certified SAMHSA provider for medication-assisted treatment. We'd be looking at getting that done so that we can then utilize methadone as a primary source of treatment. In the interim, we would be looking at using naltrexone and the buprenorphine as the primary ways to treat individuals with opioid use disorders and helping them to resolve that and overcome that. So next slide, Dustin.
Just a quick question.
Yes.
So in other words, we can't use methadone now. We have to be certified to be able to use it. Right?
Madam Chair.
Yes, go ahead.
That is correct. So it would require additional training and certification for our clinic and our clinical staff to be able to do that.
So, because I'm kind of trying to catch up with this, we had a MAT provider up in Valley County that passed away last year, so we don't have a MAT certified technician up there to be able to treat. Right?
If that was the only provider, Madam Chair,
Yes, go ahead.
if that was the only provider that was available in the county, then we'd have to look at how we could help to certify or bring in additional resources to help providers become certified to be able to provide that level of treatment.
That's awesome, because that's what exactly was my next question, is if we could bring our folks down, because I know we have quite a few substance abuse counselors, that kind of stuff, that would love to have that. But
This is just a quick overview of the different types of medications that are used and how they impact opioid use disorder and how they work in the brain. You can see methadone is a complete antagonist that provides complete coverage. It's considered a full agonist and generates the same equivalent effect as the opioid. The buprenorphine is considered a partial agonist, and you receive a partial result. And then the naltrexone is an antagonist that is a blocker. It prevents the receptors from being engaged at all. So this kind of outlines and it goes along with the effectiveness of each of the different types of medication. And again, of course, the goal would be to become a clinic that's certified and able to utilize methadone as the primary source of treatment. Next slide, Dustin. As we look at some of the goals that we'd like to accomplish with these funds over the next couple of years with this program, Primarily, we would like to deliver patient-centered care and education to help patients make informed decisions regarding the different types of treatments that are available to them, helping them understand the different pathways to recovery, and helping them to engage with the community resources that are available to each of them to continue to move forward with that. We'd like to refer patients to other medical, behavioral health, and community resources to help continue their pathway to recovery. We'd like to utilize the infrastructure that's already built throughout our healthcare system, both the behavioral health side and the medical side, to ensure that we're utilizing the resources most appropriately and most efficiently throughout the four-county region of the district. And then we'd also like to, through campaign and marketing, we'd really like to work to destigmatize the medication-assisted treatment by increasing public awareness, integrating person-first terminology, and making sure that clinic services are accessible for individuals with opioid use disorder, and that it's not viewed with such a negative stigmatism. That we're actively seeking ways to help people find treatment and help them be successful in their treatment pathways. Next slide talks about some of our intended outcomes. Again, we're going to talk specifically about assisting patients in overcoming barriers to accessing MAT treatment. MAT treatment is our medication-assisted treatment. We want to make sure that those barriers don't exist, that if we are lacking resources in specific geographical areas in terms of providers, that we're helping to find ways to train and resource those providers appropriately to help them with meeting the needs of the populations within those frontier and rural communities. We'd like to establish a hybrid MAT model, including on-site telehealth work going on in our clinics with our substance use disorder treatment, for a community provider and partnerships that we have with many of the other different groups and agencies and medical providers throughout the district. We're looking to improve retention and engagement in evidence-based overdose prevention strategies. And again, this will be in addition to the strategies that we're already using throughout the district in our health promotion and policy contracts and work that we're already engaged in regarding substance use disorders, and the work that we're engaged in each of the counties regarding that. This would be to improve that, to augment some of the services that are already in place, and to help facilitate the effectiveness of that and the retention of the services that we have. We'd also like to develop an enrollment toolkit to support individuals with insurance and the ability to maximize their benefits and connect them to medical providers that are already able to provide them, and they have methods and means to pay for these services, making sure that that is well aware of, understood, destigmatized, and available to people who need to utilize it. And then finally, we'd like to have the outcome of raising community awareness of services by overall destigmatizing medication-assisted treatment. So those are some of the intended outcomes and goals that we have for this funding and for the program in general. Are there questions so far around any of those goals or outcomes?
Curtis, some of these dates here, or goals as far as, do you have a ballpark date of when you actually are going to hope to start treating patients?
So we'd like to start treating patients within our own clinics as soon as we can. There are some things that we can start doing immediately in using some of the medications that don't require additional certification and education and training. So that is something that we can look at implementing now. I believe we even have some clinical staff that are already in process or have recently received the certification necessary to start treating with some of the medications that don't require SAMHSA approval. So we're in a position to start moving through some of that right now. If you look at the next slide, Dustin, next slide, please. It starts to outline our year 1, year 2, and year 3 objectives and goals. So one of the things that we'd like to look at doing in year 1 would be to hire a project director as part of our health policy and promotion team. And then also looking
Madam Chair,
Yes, Megan, go ahead.
I'm sorry to interrupt but I have some concerns having looked at the slides and read them prior to the meeting. And the one is in year 3, you look at complete sustainability report indicating diverse funding streams and ongoing expenses. I know that we require state agencies to provide a federal funds report with an exit strategy should the funding stream be cut off. And I'm just wondering why that study is not done in year 1 rather than waiting to after 2 hires and funding a full program?
Go ahead. Thank you for the question, Representative Blanksma. I think the short answer to that is we anticipate continuing to receive these funds for over the next 18 years. So we do identify these funds as somewhat stable and ongoing, at least for the next 18 years. I would also add that our revenues indicate that we have already received approximately 3 or 4 years worth of funds. And so we have that money in receipt already and don't anticipate any issues with funding during this first 3-year implementation cycle, which is why I think the review of the evaluation was scheduled to occur in year 3.
Does that help, Megan?
It does, thank you.
Madam Chair, I have a question. Kind of
Yes, Al, go
maybe
ahead.
more towards moral, but do we have to put this money in a separate account, a separate trust, and then keep track of
Yes,
those
go ahead.
expenses and all that?
So we track it all by PCA or program cost accounting codes. And so any funding stream that comes in, it has at least one PCA assigned directly to it. If there's a reason that we have to track any pieces of that separately, we just assign another PCA, usually close in number to what the initial one is. So there's a family of PCAs, sometimes for one funding stream, sometimes one PCA per funding stream. But yes, we track it as specifically as we need to for any reporting that's required. And I'll add on to Representative Blanksma's question that we are still doing annual reporting. So although the sustainability report, which might be looking at the diverse funding streams and ongoing expenses that might be represented in year 3, there's still going to be annual reporting that we're doing for budget planning and all of that. So it's not exclusively happening in year 3. We'll continue to do the financial and grant reporting that we do on an annual basis as well.
Thank you for adding that. I appreciate that.
Sure, thank you. Okay, so year 1, we look at hiring a couple different individuals, a project director and a healthcare navigator. We look at establishing the internal policies and procedures for on-site MAT initiation, induction, coordinating care. We would also like to bring these individuals in to participate in full services within our clinic in terms of looking at other communicable disease transmissions, testing, treatment of any other at-risk populations for this group. We'd like to coordinate with our clinic on the different practices and strategies to incorporate MAT treatment into the clinic, and we'll be looking to train staff and issuing an RFQ to contract for outpatient MAT and SED treatment referrals and public awareness campaigns. So that would be looking at year 1 at the activities that we'd be looking at completing. Year 2, then we'd be looking at introducing methadone into Ada County, as we be hoping to complete all of the training and certifications necessary to be able to conduct methadone at the clinic. And so then we move forward with that as a way to treat in the clinic for medication-assisted treatment. We'd be implementing all the year 1 policies, procedures, and lessons then that we had picked up from Ada County, and we'd be looking at implementing those into Elmore County and moving those practices and procedures into clinic at Elmore County and how we implement that across that county as well. We'd then be implementing telehealth and MAT initiation and appointments in Ada County and assessing Valley County for capacity for MAT implementation and moving forward with that. Year 3, we expand more services into Valley County, Boise County, and start to ramp up our development for MAT induction implementation model for the replication of services in other public health districts or with other community partners. And then we work into completing our evaluation and sustainability reports to ensure that this is a sustainable model that we continue to support in our clinic and continue to support with the funding that we anticipate receiving over the coming years. Questions regarding that 3-year plan?
Floor is open for questions or discussion.
Madam Chair, I guess my only one question is, what do we do for Boise County? They are part of this district.
They would be in a similar position because we don't have an actual clinic in Boise County. Most of those patients and participants end up coming to our Boise office, and so they would be included in any of the Ada County procedures. Okay, next slide, Dustin. This is an overview of the types of visits that we'd be looking at providing, starting with a pre-induction initiation visit with the MAP provider. Providers are, there are specific things that they meet with the patients to conduct and perform. There's the induction visit following that where they do urine testing, screening, fentanyl and other drug panel screenings. Several other different things can occur during that. They'll be meeting with a healthcare navigator to complete a social determinants of health survey and screening and trying to assist them with community resources and the partnerships that we've developed to help address some of those needs that patients may have identified during that social determinants of health screening. We start to talk about overdose prevention and response, distribution of prescriptions and safety supplies. We'll complete required confidentiality agreements during that visit. We then move into maintenance visits where providers will continue to meet with patients as needed.
Madam Chair?
Yes, Megan?
Yeah, if I may, I have a question.
Yes, go ahead.
I just wanted to kind of dovetail off of what Commissioner Hasbrook said. Is there a way to set up a type of mobile service for Boise County or something like that rather than requiring travel to Ada County? Or does the treatment actually prevent that?
Madam Chair. That is a good question. I don't know the answer to that. I believe to some level, some of the certification requires site certification. So while we may certify a site in Ada County as being certified to perform those services, we can look into the option of also certifying like a mobile clinic that could provide those services on a mobile basis in other counties as needed. I can research that and provide additional information to the board if you desire.
Thank you.
Yeah, Madam Chair?
Yes, go ahead, Megan.
Yeah, I actually think that would be a really good idea rather than just assuming that Boise County residents will drive into Ada County, because for folks that have this kind of issue, we want to try to make it as convenient as possible so to increase access.
Thank you, I agree. Go ahead, Curtis.
Madam Chair. I think one of the key components of these visits will be working with the healthcare navigator, who will be providing specific services that are less clinical in nature and more resource-oriented in nature on helping patients to find the necessary services that are available within the communities and helping link them with either medical, behavioral health, or other services that they are in need of based upon that social determinants of health survey and screening that was completed. So a valuable resource to individuals who are experiencing substance use disorder and having an advocate that will help them to identify and utilize the resources that they are in need of. All right, next slide. This next slide outlines the dollar figures that are associated with each year. You can review those and look at those. There's specific categories that are there. We're looking at several different personnel outlays, supplies, contracts. Contracts specifically are referred to for marketing as we look to do different marketing and incorporate a marketing campaign into the destigmatization of MAT treatment. And then we'll also be looking at potential other operating expenses if there's any changes that need to be made in our clinic to become certified or things that need to occur. Make our clinics in the 4 counties accessible to and conducive to utilizing the medication-assisted treatment. So, questions regarding this slide of the dollars?
Yes, Al, go ahead.
So Curtis, this is for 3 years, $1.2 million, so that's about a little over 400,000 a year to start it, correct?
Yes, go ahead.
That is correct.
So your first year is probably the most expensive.
The way we have it outlaid right now, because we'll be expanding services in years 2 and 3 to additional counties, we do see additional increased expenses in those additional years. Mostly based on as we expand to different clinics, if we need to hire additional staff to provide services such as the healthcare navigation services out of Mount Home or McCall Clinic, we then incur additional cost for personnel.
Well, oh, I'm sorry, go ahead.
Jane? No, I was just gonna ask, is there a plan for how to get the people to come?
Madam Chair.
Yes, Curtis.
I believe part of that will be built into our marketing campaign that we would have, where we would make this a well-known and understood treatment. Then we would market that specifically to the target audiences and populations that we'd be looking to bring into our clinics. I think we would also look to utilize it with the existing clientele that we're already working with and the patients that we're already bringing into our clinics as we continue to assess their needs as we're working with pregnant mothers, young mothers, individuals coming in for communicable disease treatment and testing. We'd be looking to offer additional SUD services if they're required and needed for that population of people. In addition to that, we'd hope to attract new patients and clients to our clinics by offering this new medication-assisted treatment service that would also increase foot traffic into our clinics and into the services offered by the district, so that they may be coming in initially for substance use disorder, but then we can also bring them into our communicable disease testing treatment. They may be eligible for WIC, they may be eligible for other services that we can pull them into and help them participate in to provide a comprehensive and fully burdened way to treat them and help them in multiple avenues rather than just the initial one that brought them to the door.
Seems to me that the easier, I agree with Megan, the easier we can make those visits happen for people, especially like in Boise County, the more success we will see. And a question too, Curtis, for you, before we move on. We have a drug court in our county which has like a 60% success rate. Are you going to be partnering at all with them in any respect?
Madam Chair.
Yes, go ahead.
That is an excellent idea, and yes, I would foresee us utilizing all sorts of partnerships as we identify those as we move forward into the program. I think one of the things of both the project coordinator and the healthcare navigator will be to identify community partners, find ways to work with them and identify services that we can offer jointly or how we would work with them. And that would absolutely be an effective way to utilize funding, establish services, and work together with our existing partners as we develop and further along the partnerships that we already have in existence.
Great, thank you.
Madam Chair,
Yes,
follow up.
go ahead.
I think that's a great idea, a great suggestion, because I know in our court system, they're required to take certain classes, certain intervention stuff, and we could become one of those. And then I'm assuming we would get Medicare rates on that. Those individuals, we get money back. Is that correct? From the actual person, the
You mean
inmate, so to speak.
Medicaid rates.
Medicaid rates, which is what jails pay.
Yeah, Madam Chair.
Yeah, go ahead.
Yeah, and that's part of that long-term sustainability plan, even though we have 18 years of funding. Anytime we get revenue coming in from grants, to Representative Blanksmith's point, we immediately start looking for other funding streams, and insurance, whether it's Medicare, Medicaid, private insurance, is something we build into that. We never spend the one-time funds, as I would say, even though it's over 18 years, if we have other sources of revenue to allow us to basically, we're trying to build a timeline out as far as we possibly can. To use grant funding, just like what you all did for Nurse Family Partnership when we talked about the December and at the January board meeting, is that was allowing us to get started, but immediately start billing insurance, in that case Medicaid, to help maintain our pool revenue.
Follow-up question.
Yes, go ahead.
You know, is there other pharmacies that are still in litigation? There could be future settlements. I think there is.
Yes, I think so, yes.
Yeah, that's what we've been advised, but not been provided any, like there's no assurance, like this is a dollar amount, but all along as these initial settlements were being reached, that there'll be more coming. But that's about the level of
And I
detail.
think the last one that lost, it was a 3-year payment. They just paid it each year. Is that correct? So it's not going to be every year funding. We have to spread that out over the 3-year period. If I remember right.
Madam Chair, yeah, they did, and I don't know what the exact dollar amount is, but we received a lot of money up front. So that's something that we're also keeping in mind as we look at our implementation plan is not to get too far out ahead of what we know the future revenue is.
Well, and I think it's gonna be nice now because we're gonna know somebody in the Attorney General's office that can let us know when the next one comes in.
Right.
That's right.
Right, Ralph?
Did you get that?
I did get that, yes.
Okay. No, please, thank you.
I think, I guess one more comment, the other thing I'm concerned about is the year one, two, and three, that's a 10% increase every year, so we're gonna have to really make sure we don't outgrow our pants, this one. But I think it's great that we're getting this started. We really need this in Valley County.
We need it everywhere.
The other thing that I think is gonna start, I hope starts kicking in a little bit more is the fentanyl issue, and there may be some, some funding coming from state or feds that we can dovetail into this whole program and treat that issue as well.
Hey, Curtis.
Thank you, Madam Chair. Accept the next slide, please. Previous slide, Dustin. Looks like we're missing a slide.
Well, we got it here.
Need a slide.
It should be in your presentation in your
Yes,
handout.
it is, it is.
Just wanted to reinforce the medication-assisted treatment has improved patient survival rates. It helps with patient outcomes tremendously. It increases retention in treatment, and that's one of our primary goals is as we provide medication-assisted treatment and they engage in other outpatient community treatment. This helps with retention and success in those endeavors as well. It decreases the illicit use and activities of people that are experiencing substance use disorder, and it increases patients' ability to gain and maintain employment. Of specific importance is it improves birth outcomes among pregnant women who are involved with substance use disorder, and it lowers the risk of contracting other communicable diseases that we spend time and money treating and testing for. So there are tremendous benefits from engaging in this type of activity. We see an opportunity to move forward with the funding that has been issued, and we would like to propose this type of a plan moving forward and look forward to getting into the details of how we work to implement this type of a plan over the coming 3 years. I'll stand for questions.
Madam Chair,
Yes, Al.
I think another big advantage of this, I hope anyway, is that we will start getting data on where our bigger users are, whether it's in seniors or it's in teenage use, so that we can get more specific on some of our programs and our programs where we should be putting our emphasis on this kind of treatment. If it's all in 20-year-olds, then we need that data, I feel like. Hopefully we can get that data from this as it starts building and growing. We can see where the big issue is. I don't know, maybe it's the geriatric age, I don't know, but I think that's important to have the data.
Yes, Curtis.
Madam Chair, good news on that front, Commissioner Hasbrook, is we recently met earlier this week with the Department of Health and Welfare, and they are working on the development of what's called the overdose map, which will be a real-time, and it's already employed in some counties and states where they are looking at real-time data based on emergency response for overdoses, where they are mapping, and you can see hotspots on maps of where overdoses is occurring, neighborhoods that is prevalent in, regions of districts and states that is prevalent in, that we can then utilize that data and information to focus treatment, marketing, and additional information to those specific populations.
That's awesome, because as a commissioner, that's the stuff that I'm interested in. Like in our area in Valley County, our big issue right now is most 78% of our people up there are over 68 years old. So we know that down the road, we're going to need more assisted living facilities. So that gives us direction on where to go to next. Awesome. That's good news. This is great.
Okay, thank you, Al. Any further discussion or questions for Curtis? Okay, thank you, Curtis. Look forward to progressing on this terrible issue. Okay, next on our agenda is our director report by our director.
Thank you, Madam Chair. I'll be brief. Laurel alluded to this in the budget presentation, but on Wednesday this week, I sent out an email to all staff letting them know about the board's decision at the August meeting to support what we refer to as retention incentives. They have a structure based on basically 0 to 6 months, 6 months to 3 years, and more than 3 years, a tiered incentive that will be processed next week and paid out the first paycheck in January for our staff. So we thought the timing would be great. As we all know, sometimes we get extra bills coming in after the holidays, and a nice, I think, a reward for them. And I wanted to also share just a lot of really positive feedback and emails that I received, that staff appreciated that. And on the retention side of things, you never quite know precisely what causes that to happen, but we have, I asked Gary Footer, HR manager, just for what we've seen over the last 4 months, and the decline in people or staff voluntarily leaving the organization is pretty dramatic. So I asked him, it's a crystal ball look rather than anything scientific, but thinking about where we might be. I report this back to the board. Likely it'll be in August, possibly look at doing this again. I think we will have cut our turnover by almost half based on what we're experiencing just in the past 4 months. So it's a big deal. Obviously, it's not something we can do maybe forever, but we definitely have one-time funding in our budget now that we've not historically had, the dollar amount, because of a lot of the COVID money that came in, and staff were charging their time to those federal funds that allowed us to save some of our local dollars. And again, it's one-time money. And this is a great way to show appreciation for our team, and definitely made note that it was board's decision and board's approval to allow that to happen. So I thank you for your support to allow us to do that for our staff. Big deal. That's all I have.
Thank you, Russ. Okay, that does bring us to the end of our agenda for today's meeting. I would like to thank the public for participating, our visitors that have come to sit in on the meeting. Special thank you to our administrative assistant for her holiday surprise packages. They're always a delight. And just moving forward for next year, we are looking forward optimistically to the progress that we can make in the field of public health. And on that note, I will entertain a motion for adjournment. By the way, our next meeting, as we stated previously, is scheduled, has approved on our calendar, February 17th at 8:30 in the morning. So at that point, I'll entertain a motion.
I'll second James' motion.
Oh, okay. I guess we have a motion and a second. We'll call for a vote by county, starting with Dr. Young. Young, aye. Raul Labrador. He stepped off. Dr. Colesman on. Megan.
Aye.
Okay, thank you, Megan. Boise County, Ryan.
Aye.
Thank you, Ryan. And Valley County.
Mr. Hasbrook, aye.
Okay, thank you. Motion's been approved for adjournment, and happy holidays to all, and goodbye.
Well, good night.
Yes, absolutely.